Thank you for the question. There are many, because it's a very common condition. Around half of us will have syncope in our lifetime. And for some, this is a great burden because they have many. And it begins with what you do when it happens. And many go to the emergency department. And there it's not always managed as well as might be, so this is a challenge to improve. Too many patients are admitted to hospital for tests which have no value but cost a lot of money. This is another challenge. Diagnosis is made only fairly well by general physicians. They could be family doctors or internists. And they will diagnose roughly 60% of cases of syncope, providing an etiology. And then when you have an etiology, you can think about treatment. Before, it's difficult. So if you have a syncope expert, of whom there are very few, you may have 90% of diagnoses, or even 95%. There will be a few that don't easily get diagnosed. So how do you get a lot of syncope experts? That's another challenge. And the answer's difficult because you need to be very interested in that problem. There appear not to be so many. And then they have to be trained and practice all the time. And probably write about their experiences and be willing to read other people's experiences and papers. So after that, there's what is the treatment? The short answer is none, but there are treatments which will help, but there's no cure. So we would try to modify the patient's lifestyle and maybe occasionally give drugs, and very rarely a pacemaker. So diagnosis of syncope is absolutely essential, and the new approaches are really not so new. We haven't anything that's magic that's occurred very recently. But we have the tilt test, which I was partly responsible for introducing to clinical practice. And this has rather diminished in appreciation in recent years. This is unfortunate because it's still valuable, and many patients can get a diagnosis this way when their physicians have not been able to make a diagnosis. And it reveals a lot about the physiology of the particular attack the patient is having, and might prompt a specific treatment. I emphasize might, but tilt testing has been reappraised in the last few years as being more useful to predict the response to treatment than it is to make a diagnosis. It still has value as making a diagnosis, but if the tilt test is positive, then any treatment we can offer will be less good than if the tilt test is negative. The reason for that is a little bit complicated, but fainting, syncope, is due to two phenomena. One is that the blood pressure goes down because the blood returning to the heart is reducing. So it's gone somewhere, mostly in the abdomen, some in the legs, the patient standing up. And this always happens, but there may be slowing of the heart rate and even stopping of the heart. Now, if that happens, it conceals the first phenomenon I described. So in a tilt test that's positive, that may happen. The heart stops. So it's difficult to appreciate the lowering of the blood pressure, or more difficult. And so if the tilt test is positive, especially with asystole, but if it's positive, then the results of treatment, whatever it is, will not be as good as if it were negative. Perhaps in very crude terms, it means something about severity of the attack. A very severe attack will be more difficult to treat. It's easy to understand. A not so severe attack will be easier to treat. Well, they're quite large. Syncope constitutes about 1% of attendances in the emergency department. So that's an appreciable percentage of the emergency department's budget. If the patient's admitted and up to half of them are, that's a great expense because they get brain imaging and electroencephalogram and also the useless tests because they never give a diagnosis, but they cost a lot of money. So this is a big problem. After that, then we've got recurrence because people with syncope tend to get recurrence. So the same thing can happen all over again. If there's 5 years between, reasonably the patient thinks, well, this might be something else, although it felt the same. So a whole lot more investigations are done. Economic burden is high of syncope, and it's been calculated in the US as being something like $2.5 billion per year, and that's about the same as the budget for treating AIDS. The question of algorithms, this is really putting guidelines into computers, and the algorithm drives the questions that the doctor must ask and the investigations the doctor must do. So they're bound to be an improvement, in my view. There's a danger, though, because if the doctor is not allowed to think, which the algorithm is not for doctors to think. It's for doctors to do everything correctly and not to think. If doctors don't think, then there'll be mistakes. Probably less than if the algorithm didn't exist, but we don't really know that yet. I mean, they haven't been widely enough applied. And I see them as a necessary part of this, but not the whole part.